Hello, my name is Neil Spooner. I'm the chair of the Patient-Centric Sampling Interest Group, a not-for-profit organisation dedicated to educating on these novel technologies for getting biological samples from human beings. Really grateful to ASLM for inviting us today to take part in their ECHO webinars. We're very excited about this, and we're looking forward to presenting to you, but also hearing your questions and getting your feedback. We have planned a second event for the 7th of May, where we'll be following up with some more in-depth discussions about how these technologies might be useful for Africa and how we can help move forwards. So I'd just like to move on to our speakers today. Our first speaker will be Jolene White from Biodata Solutions in the USA, who will introduce us to the existing patient-centric sampling technologies. That will be followed by Chris Hendricks of a rare cause in the UK, but he also is based at Northwest University in South Africa. And the title of his talk will be When Infrastructure Fails, Why Dry Blood Spot are Africa's Lifeline for Biological Sampling. But with that, I'm going to hand over to Jolene and see you on the other side for the questions. Are you there, Jolene?
Yes, I am pulling my slides up. Thank you. Hi, my name is Jolene White, and I'm very honored to be speaking with you today. I do have a quick disclosure. There we go. Feel free to reach out to me on LinkedIn or wherever you feel most comfortable. I'm always happy to work with my African colleagues. I do have a potential conflict of interest to disclose, which is that I used to work for Gates Medical Research Institute, which is another grantee of the Gates Foundation. But since they also do issue some grants to some of these device developers and manufacturers, I did want to disclose that I'm not favoring one over the other. I'm really just trying to give you a broader view of what is out there that you may or may not have been aware of. I am using a lot of images under Creative Commons licenses, and the others are from product websites where I've tried to disclose the trademark owner where within the images and slides. So what is patient-centric sampling in general? The key item is that traditional, or what we're calling conventional blood sampling, is really just venipuncture, which means that an individual needs to come into the site, that they have a needle puncturing their vein, which they can see. And then there are vacuotaners, which rely upon a vacuum in the tube to pull the blood from the patient quickly into the tube. But this isn't necessarily the easiest route for the patient. So when we talk about patient-centric sampling, what we're talking about is a variety of factors. One is making sure that the right sample is collected, that you're not collecting samples that aren't needed. Using processes that are convenient for the patient, that aren't asking the patient to conform to your process, but rather developing a process that meets the needs of the patient. Where the data is high quality, so this includes making sure that those samples can go into assays that are generating the needed data to then make those high quality decisions. That if data can't be used to make decisions, no matter how good it is, then it's not particularly helpful to the patient. It's more of a research question. And if the patient is interested in research, that's one thing. But sometimes it's generating noise, at least in Western society or the US and Europe. What I'm focusing on today in my talk, but but Chris will be going well beyond that, is really what are some of the technology solutions, not people. People are at the center, and you are at the center of finding the right solutions, but there are technologies that can help you. And these are some of the challenges that technologies have been trying to solve. Collecting less, replacing the venipuncture, which can be, a little traumatic for people who either have needle or blood phobia. Collecting by themselves, having more stable samples in order to get those samples, get high quality data out of them. Sometimes you need more precision than what vacuutaners can deliver in terms of blood draw, and enabling transport solutions. And there, of course, are some technologies that improve transport, although I won't be touching on those today. Chris may, and certainly I'd be happy to touch on that during the Q&A. So on this slide, I really want to touch on what are some of these solutions and how do they interact with different pieces of what you might be looking for. And I will fix this slide before it's sent out because I realize this Neoterix is actually blocking the image of this picture. I will try and do it live, but that's not always going to happen. One of the device technologies that has been implemented is that in addition to dried blood spots, there are now some plastic devices, which you can imagine some analytes will be easier to extract off of a plastic than off of a paper, like the traditional dried blood spots, which I'm assuming everybody is familiar with on this call. And also there's some devices that are volumetric. So that includes both this particular plastic device as well as over here on the right. I'm going to make my pointer a little more obvious. Okay. Over here on the right, this also is using the paper substrate that's commonly used in dried blood spot, but uses fluid control through this paper device to ensure that a very precise volume of blood is collected. And the same over here. There are devices that simply remove the vacuum from the tube and are essentially using capillary blood. The Sarset device is one that I'm very familiar with, as are the BD microtiners, which are designed to really collect blood from a smaller volume from a capillary blood lancet. But what I'm showing here for BD is that they also have a fingertip device that connects to their microtainers that essentially makes this whole thing a little bit more integrated, so that you're essentially, for the patient, it's a single device as opposed to a lancet followed by collection. Here's another paper-based device that you may be able to tell from the subtitled separation on the spot that in addition to collecting a dried blood sample, as shown here, it also separates that blood into different components so that you can then work with something that is a little bit more plasma-like. And then there are devices that are designed to go on the upper arm. I'm showing only one of them here, which is the Tasso device. And you can see that instead of doing a finger or heel lancet, the device itself is put on the upper arm. And then this big red button is pushed to put a lancet straight into the upper arm for collection, which can be less painful for many people than the nerve-rich endings of your fingertips. And I also wanted to include an item which I happen to know is not available in Africa as an illustration of one of the challenges in implementing these devices. This is a device called Tenderfoot, which you may be able to read on the device itself, but it's in relief, so it's hard to it's harder to read than what a lot of device manufacturers do. And what they do is they have different lengths of heel lancets that are designed to be adaptable so that you can pick the right length for your particular infant, generally based on age, but it's by depth of penetration. And instead of a puncture lancet, it is a shallow slice, which in some studies has been shown to be less painful for infants because it's a more controlled distance. And what they try to do is, not really, what they have done is determine the right lengths for different skin depths so that they can do a very shallow cut and get access to the blood capillaries without penetrating as far as the nerve layer. So it is less painful for the infants being sampled. And then there's another one that I wanted to point out that it's not just blood. This is a swab device. It is not a cotton swab. It is a plastic-based swab that fits into a little 96 well sized tube for collecting nasal swabs. They also have swabs for other parts of the body, and then they also have one that is a capillary blood collection as well. And then here is a device that is PIP, stands for pee in pot. So it is a urine collection in a biodegradable collection suit that you can see as the dot in the eye. So there's a lot of different devices, and you can find a list of all of the ones that we have been able to identify through PCSIG on our website. And that includes lancets, blood collection, and other sample collections. There's no one size fits all. And here you see the traditional dried blood spot cards. Most of them are based on Whatman paper, but many companies have rebranded versions and different coatings. And you can see in this slide that there are different coatings, even on the dried blood spot cards, that are available for different purposes. So even dried blood spot is not a one size fits all. So the technologies that are developed are really generally developed to solve a very specific particular problem, which means that if your problem is not the same, your solution may not be the same either. So a really simple, straightforward example is that dried blood spots are excellent for the heel prick newborn screening. However, they are obviously terrible for doing complete blood counts because all of the cells will be lysed on the paper and not usable to measure what your blood counts were. So what that means is that alternate approaches do solve different problems, and there is no single approach that will solve all problems. So on the previous slide, you may guess that some of those solutions are not inexpensive. They have a heavy cost burden regardless of the geography relative to a vacutainer. However, sometimes the total cost can still be lower if you can decentralize the collection. So the cost of the device might be more on paper, but that doesn't necessarily mean the cost of the full process is. And so all of those factors can determine what solutions are implemented. And we would like to, of course, encourage ASLM to think about some of these questions, both for our Q&A section today, as well as for the panel discussion we are planning on the 7th of May, same time, right here with you, which is, who are the patients that are currently underserved in Africa? You know that far better than I do, coming from the US. I may have greater exposure to some of the technologies, but without exposure to the challenges as a day-to-day capacity, I am not able to advocate for what you need as adaptations of the solutions we have, other than my constant refrain to manufacturers that they should be manufacturing and selling their products in Africa for your ability to use them. Are there solutions that haven't been possible before that patient-centric sampling opportunities can help solve? Do the existing technologies, and which ones, help solve challenges that African scientists yourselves are facing? And which challenges none of the existing solutions work for, but you have an idea in your head of exactly what performance you need from a device, including cost, and can patient-centric sampling interest group help you advocate for that with manufacturers or researchers, or even help you develop your own new devices? So one of the reasons that I personally am excited about working with scientists in Africa on this is that there is a huge opportunity in Africa relative to the US, where I am based. In the US, there is a huge barrier to innovation due to maintaining the status quo. In the US, there is extremely heavy capital investment already in vacutainer automation. So these labs, these big clinical labs, have absolutely no motivation to move to alternate technologies that make those automation pathways obsolete. That's where they're getting their competitive advantage in pricing. So they certainly don't want to give it up in favor of a process that is more friendly to the patients, if it means that they have to invest a lot more. So the other aspect is, in the US, assays that are already approved for 510K, which is their approval pathway in the US. If you then change that method to use an alternate sample, then the lab has the burden of conducting additional validation for that assay, which again is different cost. I will quickly go back to the question about, why is dry blood spot terrible for CBC? And the reason is because when you put the cells on the paper, to get the cells back off the paper intact, it has been pretty much unfeasible. That the extraction buffers essentially, or even the process of depositing the cells on the paper, causes the cells to lyse. So once they're lysed, you can't count them, because now they're just a mass of membrane, cytoplasm, nucleoplasm, and you can't actually count how many cells were there. You may be able to do other things, and there's certainly alternates that people have been looking into on the technology side that also addresses, can we measure things like the different types of RNA that are expressed in different types of cells to essentially get a different measurement that answers the same question as complete blood cell count. But that's a different topic that I can get into today. But if that's something that people are interested in, certainly something we can touch on in the May panel. So for ASLM, Africa will have different barriers to innovation. And I personally feel, from an outside perspective, that there is a lot more openness and interest in innovation in laboratory medicine in Africa, which is why I'm excited to talk to all of you. That there are cross-country efforts that could potentially be leveraged. The African Medicines Agency has put out some information about cross-country device approvals, and all of these patient-centric samplings are also considered medical devices. How would you build diagnostic access completely differently by putting patients in the center? Is this something that you personally would do something very different? I've seen excellent solutions coming out of these LabCoP, laboratory community of practice webinars that I've attended as a interested party that I would never have thought to build in the US. And so you know already many different ways to innovate that are based on your realities. Who are the stakeholders in diagnostics access and reimbursement? In the US, the stakeholders are, it's a lot of money, and it's private industry and it's government. But that's not necessarily who it is in Africa. And then the regional nuances. This is why I put the outline map of Africa, which I apologize. It is not, the borders are not up to date with all of the existing countries in Africa. However, what I wanted to emphasize is that in the US, while we might have 50 different states, there is an overarching regulatory framework. And in Europe, there is the European Union. And in Africa, well, there are strides to have a cross-continental. There are a lot of regional nuances, even if the governance is regulated. The reality of patients and people are different depending on where you live. So what I wanted to touch on is what are some of the shared principles of access for all patients in all locations? What are some of the potential applications that come to my mind when I look at this from a outside perspective? And these are some of them. Infectious disease is a huge potential application because there are opportunities both in pathogen identification, serological surveillance, as well as treatment monitoring with HIV viral load. If you can test people in where they are rather than in a centralized location, you can reduce the risk of spread during the testing event itself, as well as potentially getting better sample collection close to the potential infectious event. What about some of the diagnosis that is happening too late in the process or not frequently enough to help patients? Would it be helpful to understand risk factors? Are the diagnostic trees incomplete because people who are at risk aren't getting referred as frequently as they can to the specialty labs? Are there opportunities to monitor disease progression in order to know when the treatments need to be changed? And then another element that I think is often overlooked in many places, including the US in pediatrics, is establishing what normal ranges are. And in order to do that, you need to have samples from this collection. So you would need to be able to collect samples. And are those normal ranges accurate? Are they establishing it for the full range of patients right now if you're only collecting samples from a limited population that happens to be close to the centers establishing these ranges? And then another is treatment monitoring, such as therapeutic drug monitoring, which can be very important for things like looking for are the drugs still working in someone, side effects, many drugs have liver side effects, that if you could monitor them more frequently, you could make it safer for patients to identify when they are at risk for side effects. Measuring the therapeutic targets to hopefully separate out, as well as supporting clinical trials, which is an area where currently the African labs are underutilized. Even when there are clinical trials in Africa, the labs that are being used to support them are not always based in Africa. And then as we are emerging into the area of telehealth, obviously you're not coming into a lab to see a provider, so you're not coming into a lab. So is this an opportunity to collect samples either in advance of or as a result of telehealth visits? So where next? The roadmap isn't clear. There's many different destinations. And then these are my favorite road signs from both England, because the barriers are sometimes the things that you don't want to change. You want to keep your dung beetles and otters. So how do you work with those to make a solution that works for your reality on the ground? And then here is a link using QPS code, so that on the replay on YouTube, you can quickly find it, plus an email to contact us. And then we also offer opportunities and recordings that allow you to see sort of some of the things that we've been talking about in patient-centric sampling across the globe. And of course, I would like to thank you for your attention. And I will be answering questions in the Q&A as Chris starts his presentation, which is on a very specific use case in South Africa. He's based in South Africa, but covering the continent of Africa in the area of rare diseases. So thank you so much for your attention. And I look forward to more discussion with you in the Q&A and in the May 7th session. Thank you.
Thank you, Jolene. Thank you. Very informative. So we're going to save all the questions to the end of the session. Please add your questions to the Q&A. I see there's a few in there already. It'd be great to get your questions in there so we can have a really good discussion. But I won't take up any more time. Over to you, Chris.
Thank you, Neil, and thank you for ASLM for this invitation, because this is something that's incredibly passionate for me. I'll just have a quick introduction. The accent usually gives it away. I'm South African, but I had a child with a rare disease which couldn't get a diagnosis, which is why I moved to the UK. And that is exactly why this is something that's really close to my heart. However, saying that, I do have to give you my disclosures. And the one thing I can say is that in rare disease, you realize there's bias. And I come with bias all the time. So all of my disclosures are biased towards making the lives of people with rare diseases better. And I'm going to share with you what we've been doing. And just for context, I qualified in South Africa. I worked for 10 years there. I've worked more than 20 years in the UK. But in those 20 years, I continued to support people and working in Africa. And as I have an AI data company, which I will not talk about today, I do always have to put in a disclosure as potential, as some of the images will be AI generated. But let's move on. Well, where did it all start? Well, everything started the first time in 2019. After having worked in Africa for a long time, we decided that actually we have a problem, but Africa has always been an innovator and we need a solution. And we know rare disease patients are usually the most innovative population. So let's start. So what we did is we set up a virtual advisory board. We know that due to the limitations of technology and also power outages and all the other things, that this needs to be different. So we set up an asynchronous process to gather data over 30 days and really to start thinking about, so what are the problems if we're going to try and solve some of these problems, how do they fit into everything? So this is just a brief outline of what it was and to show you when it happened. And what we found was that we had multiple countries joining, which was incredibly helpful. Of course, from both United States, Canada, and the UK, we brought some of the high income country perspective. And then we had a lot of the African countries presented. And there is a full report on this if anybody's interested in it. But really what I wanted to show is we had full input from multiple African countries, because the question was, do we need rare disease policies, and how do we solve the diagnostic issues which we have in Africa? Now you will see we had a total of 428 responses in the 30 days, and I've marked for you in red the area of interest. We quickly found that diagnostics was actually the main contributor to a lot of the problems people were facing. And the questions we got was, there is no point having a rare disease policy because we have no rare disease patients. And the reason we have no rare disease patients is because we have no diagnostics. So it was pretty clear early on is that if we're going to answer all the other questions in this big virtual advisory board we had, we need to answer the diagnostic question first. Once we've been able to do that, we may be able to make better progress. So that's why we started focusing on diagnostics. So I'm going to share with you now a little bit of our journey going forward. So we all know that the core problem is the infrastructure fragility. There are frequent power outages, there's fragmented transport networks, they're easily disruptible, and biological sampling in many African contexts has been complex and difficult. There is also the issue with cold chain maintenance. Cold chain systems are expensive, they're difficult to maintain, and risk degradation of biological samples before they're even analyzed. There's also this mismatch of technology and environment. Conventional venous blood sampling relies on ideal infrastructure. It often fails in unstable environments, causing invalid results. It's also not patient-friendly. Patients can only have their samples taken at a medical facility. Many of the patients I were dealing with were traveling up to 2 days just to get at a medical facility to have a sample taken, to be told 2 months down the line, the sample failed, could you please come back and have the sample again? So there's a need for robust sampling solutions. The diagnostic approaches must be functional, reliable, and despite the infrastructure weaknesses, we should be able to have alternative sampling methods. And this is exactly what we did. So I'm not going to talk to you about pie in the sky. I'm going to share with you what we actually did and what have we learned and potentially what you can take out of this. So we've already talked about dried blood spots. So the sampling method, as Jolene has described, involves collecting a small blood volume on filter paper from the heel or the finger and then air drying them. That's incredibly important, the drying process, and I'll spend a little bit more time on it again. It's really important that these samples are dried for about 4 hours is the average to dry them before you put them in their housing to send them away. Otherwise, you get difficulty in contamination. Now, when you are in a complex outside clinic, people say to me, where do we dry it? And listen, my African doctors did not disappoint me. They made the most beautiful cardboard boxes, cut little slits in it. They stuck all the cards in there and allowed them to dry. And at the end of the clinic, they put all the samples away. The other things that at least dried blood spots can be stored and transported at room temperature without immediate processing or centrifugation. So if you take that sample, the last clinic slot in the evening, you can let it stand overnight and do it in the morning. The DBS samples works well with modern analytics like PCR, ELISA, and mass spectrometry, and it's actually ideal for decentralized healthcare because it really makes it the suitable starting point where you've got limited infrastructure. I don't believe this is the total solution, and as Jelena said, there are multiple different solutions, but this is a starting point and it's a way to show that things can actually be done. So what did we do? So this is our, what we call our LSD Impact African Network. It is part of what we call our African Roadmap project. And really what happened is, let me quickly just get my pointer for you, is we started off and knowing that we have only the rare disease facilities to do the analytical samples in South Africa at the University of Northwest. There is a rare disease research laboratory which has been running for many years. So we know we need to have at the start a hub and spoke model. So we decided that South Africa was going to be the hub. We invited everybody who contributed to that virtual advisory board and say, hey, who wants to be an early innovator? Do you want to be part of this? And these are the countries that put up their hands first. That was Botswana, Mozambique, as you can see, Tanzania, apologies. We went up there, we've got Sudan at the top, we've got Nigeria there, you've got Ghana out there. So those are the countries which came in, and Kenya, which came in originally, and they said, we're happy to be onboarded. And basically what we did is we did diagnostic testing in something which we call the 6-plex testing. Now, just 6-plex is bias again. It's in the rare disease. It tests for 6 lysosomal storage disorders. But why did we pick that? Well, firstly, the dried blood spot test has been used in many countries for newborn screening. So we know there's a lot of validation, there's a lot of experience, and we can lift the newborn screening experience and use it for primary diagnostics. There has also been a push from many companies actually using this as a diagnostic way for complex situations. So firstly, we knew it was possible to do that. So we could do 6 conditions which we can test on the dried blood spots. We also, as the process developed, was able to know that if we found one of these 6 conditions, we could extract enough DNA from the same samples to actually do sequencing and get the sequencing of those 6 disorders. We then went further on, and with collaborators, we also developed the biomarkers, which now mean you have a sample which is both a diagnostic screening, a genetic confirmatory sample, and a biomarker which you could use for monitoring an ultra-rare disease. And that was just the conversation we wanted to have. But what we learned is that training before you start using these techniques is absolutely mandatory. You really need to get your healthcare professionals to come in to understand how the lab functions and then take their expertise back with them. And it's to train the trainer, teach local people and understand why this is so important to have the system in place to actually do it. So you will see there's then different colors. In October last year, we had additional countries asking to join, and trying to remember my geography. So it'll be Namibia, Zimbabwe, Zambia, we have DRC, we have Ethiopia coming up as well. So these were countries which said, we want to be coming in. So they've started contributing as well. So at the moment, we've got 15 satellites and 1 hub functioning in South Africa, which is really doing the testing. So let me show you some information. Oh. There we go. How did we design all of this? We designed all of it around the patient. We've always said that anything we do should be patient focused. So what we do is we always start in the patient, in the center of what everything we do. And what we do is we connect with all the rare disease patient organizations. They are critical for different reasons. Firstly, sometimes the patient would reach out to them and say, how can I get tested? So they could then connect them to a doctor which has been trained or a laboratory which could actually handle these samples. Also, once they do get a diagnosis, because we've trained our doctors and our laboratories, we would ask them, please speak to the patient organization to support the patient, because that way the patient is not getting a diagnosis without any benefit. And frequently people tell me, but all rare disease therapies are expensive. That is untrue, and there is always something you can do for a patient. And basically what we do is we then collect these 6 samples. We signed up with the CERBA Lancet Africa Network, which is a laboratory network, and they have a charitable program. And they have agreed that if we can get a sample to one of their hubs, they will then send it to South Africa as part of their program. So that's how we managed to get the samples over different things. And you'll see some outcomes now. But we also needed the medical support. And that's what my team has been doing. And I've got a large cohort of clinical professionals across the world supporting us and helping us, that we don't leave anybody after a diagnosis with no way to go. So next, how about geography? So we know that the pathology networks reduce the delay, but we also know that it's very different. So here you can see, and we do have a publication which is out, which you can follow, but this is just to show you what was the time to get a sample into the lab. So from Sudan, these are the means, 124 days. You could see, when we look at Sudan, the individuals, you can see they're all very long, between 137 and 104. Nigeria, 36, and then starting to come down. Kenya. So here you could see, and if you put it all together, the average time to get a sample into the laboratory in South Africa was about 12 days. And you could see as things were going and we learned, things were getting better. And I'm going to touch on that, because one of the main concerns why Sudan was taking that long, except for the current and the local wars and all the other things, there was also the customs issues. And I'll share with you what we've learned. But there's a lot more data on these details of this in our paper, which we've published. So, but basically, what did our data show? So on the right-hand side here, you will see this is the diagnosis that we've made. And what we know is that usually when you look at a diagnostic outreach, you have a 2 to 4% positive diagnosis. But we were hitting 45%. Because why? We were biased. We told our doctors and things, we trained them well in the laboratory and said, listen guys, if we're going to solve this problem, we need to show this works. If we report failures, nobody is going to do this. And that's why I'm sharing it with you today. It can be done in Africa. We just have to do it, and we'll share what we've learned. The other thing is, in our paper, you will see, and that's why the numbers don't line up completely, that was the first lot of countries. We now have had 98 referrals and 43 diagnoses. So you can actually see how successful this is, making rare disease diagnosis. But the other important thing is, no longer can governments now say to us, we don't have rare disease patients. We don't need a rare disease policy. We don't need to look into ways to make diagnostics more accessible to patients. So this was the most common thing for us. And it showed us that Gaucher disease was the most common. But I want you to focus on this little red circle. We also had 16% artifactual results in the first line. And these were all due to mostly collection issues. There are some limitations with analytics for DBS because of hematocrit and other variables, and we can talk at length about that. But I would hope people want to talk about that at the next event, where actually Chris Foster and the people from the lab is doing the analysis will be able to give their insights as well from the actual problems, how you QC the samples, how do you get the validations and all of that. I just want to focus and tell you guys, this can be done. Don't keep on having excuses. And we put some mitigations in, and it improved the process, and we're now in a much better situation. So what was our issues? Well, there were real challenges in shipping because cross-border samples faced huge regulatory hurdles and limited certified shipping services. So we spoke to the shipping people, and they said to us, firstly, they've done their due diligence, and DBS are non-dangerous goods. So please do not put them in a restricted cargo, because that will just get them caught, and it is not. There are many analytical things, but DBS are non-dangerous goods. The other thing as well is they said to increase your cost and your efficiency, avoid using the UN 337 classification, because that just causes delays and costs, and it stops the wider use and getting people together to work together. And it's really important that actually the regulatory alignment. Success depends on the regulatory fit alongside biological stability, allowing the samples to move freely within the existing systems. And we found out that it was very easy once we had all of these caveats in place to start moving samples around. The next thing we learned is that the customs declarations. Firstly, you have to put on there diagnostic samples because you cannot make false declarations. But please do not put in zero value, because customs officers does not work with zero. It just does not exist. Just put in a minimal nominal value. Now that differs from country to country, but in most countries, it is the lowest single nomination in currency, which is acceptable. So for most places, like in South Africa, it is not cent, it is rand. You put a 1 rand on it. And so for each and every country, you put that denominator on, because really that sample has got huge value to the patient, but no commercial value as it is. But if it's lost, it's a really thing. And then the other thing is to make sure you have proper customs declarations and process in place. So what we do is, after we've trained our doctors, we actually send them home with a pack with all of the DBS spots, all of the documentation we need, and we ask them start setting up the customs clearance system. And we actually set up a customs clearance system in advance before you send your first samples. Once you do that, it is becoming much easier to move these samples around. But all of this is legwork, and you have to do it. There are no shortcuts, and don't try and do things. What's really important for us is we need to do this ethically and keep our integrity intact, that people trust us and know it's not that we're trying to bypass systems. We are doing the right thing. We're doing what patients in the continent need. So one of the things we learned as well is that I don't need to tell anybody from Africa that climate is an issue. And we found out that actually it's not the maximal temperatures which is the most detrimental to sample quality, but actually the humidity. And especially in the tropical regions, we found that. So the higher humidity, the better the chance you're going to have a sample failure, which is why the sample drying becomes incredibly important to make sure. It's also important to make sure that DBS samples comes in a dedicated envelope. So they need to be dried. They need to go into their dedicated envelope, and then you put the desiccant in as well to keep moisture away. That way you get much better samples and you increase your effectivity. So why do I think DBS is the model for resilience in Africa? I think scientifically it's reliable. DBS has proved scientifically reliable, and we've done it in Africa, in the African context, with all the legal approvals. Logistically, DBS are logistically resilient and simple to regulate, enhancing the access and equity in healthcare. And even with delays up to 124 days on mean, we were still able to analyze those samples. So this is really good outcomes. Also, we know that DBS can act as a systems level solution. We can generate multiple samples from it. Like I've said, we've done a biological enzyme, we do a genetic extraction, and we also do a biomarker. Now, it is a powerful tool for diagnostics. The logistics and the climate is an issue. And at the moment, we are really struggling to extract DNA to do whole genome and exome sequencing from a DBS. That has been the holy grail for us. We've not been able to do it, but we are told that some of the newer technologies will solve that. We also need to start looking at potentially the use of buccal samples or saliva, but that it brings new technologies and new approvals, which we need to do. So at the moment, we continue to focus on the things we know best rather than the things we don't know anything about. So I'm going to leave you and say, what do I need? I need early adopters. I need people with guts, people who live in Africa who says we can make a difference for patients, and it's not going to be easy, but let's do it. And this is where I'm going to leave you. I know I'm biased. We're only working in rare diseases, but it was important to show it can be done. And if you looked at all the options that Jolene has given you, I think this is just the start of the journey. So let's start the journey and start making some real change for all the patients in Africa. And I'm going to hand it back there to Neil.
Thank you, Chris. That was great, really interesting case study. Really important there. And Jolene, if you can come back on camera as well, please, and then we can go through a Q&A session. So I'll just give Jolene the first question, Chris, give you a moment to catch your breath and have a look through, because I think there's some of the later questions might be for you. But let's start off with you, Jolene. So we've got the first one here, quite a long one from Guy. Thank you, Guy. Thanks for this new topic. Response to patient pain is the implementation of new sampling technology or methods, but I think depending on the utility or the use of some tools are less efficient. For instance, if we want to extract PBMCs, we need a huge amount of blood to study immune system. For that ending, are there new tools for that?
So I am aware of some tools that are being developed in order to help process to the PBMCs and make sure that they are viable when they are received at the labs. That are perhaps a little less temperature sensitive than standard approaches. I also know that some people are trying to reduce the number of cells you need. However, when you're looking for things like the T cell repertoire and the like rare specific B cells that are making specific antibodies, right now the problem is when you need a sensitivity or one or two cells, that you still need a lot of cells. It is probably one of the most resistant applications to reducing the volume of needed for the analysis. And that's based on my experience working with the biomarker group at the Gates Medical Research Institute, because, of course, in the study of the tuberculosis vaccine, PBMC collection is a core element of the trial. And so what people are doing instead is sometimes looking to reduce the number of patients that need it in a clinical trial. But when you are studying the larger immune system, yes, it is extremely difficult to reduce the amount of blood you need for PBMCs. And for that reason, some of the other collection sites aren't appropriate because you need the venipuncture to get the volume. Thank you very much for that question. It really gets to the heart of that one. You can't fix every problem with a single solution.
Thank you, Jolene. I've got a question for you, Chris. I think it's important to get this answered early. What is a rare disease? Are they diseases of genetic origin or are they chronic infections? Would persistent headache caused by migraine or vascular headache qualify to a rare disease? How best can we diagnose them and what techniques or platforms can we use?
Okay, that's a very loaded and a very good question. I'll start with the easy part. So rare disease depends on the definition of where you are. And Africa does not have a rare disease definition. It's one of the things that we really need. At the moment, we're using the European definition, which is a condition that affects less than 1 in 2,000 people or people in general. So this is a generally rare condition. That's the kind of general definition which we use, or 1 in 10,000. There are different ways of looking at it. It changes with country, and I want to give a real example here. In the UK, TB is a rare disease because it affects a small amount of people, but in Africa, it is not. So that's why, firstly, the definitions of rare, firstly, needs to be distinguished. And then what we talk about in rare disease is the classical definition is that a rare disease is a disease that affects a small number of people with a genetic origin. So yes, these are genetic-based conditions. We can't agree on how many they are, depending on how you count them. It's anywhere between 7,000 and 10,000 rare diseases. which means that about 1 in every 17 patients in the world is potentially affected by a rare disease. That is just it. So in general, they are genetic, they are chronic. The majority of rare diseases affect children. The majority of children die before the age of 5. So that's why it's so important for us to invest in this area. So in general, yes, it is chronic. We have multiple new therapies, which allows us to get people to older age and really treat them. Some of these are very expensive, some of them are not, but it's not conversations we don't mind having. And the starting point, I always say for everybody, is get some education. There are multiple training platforms if you're really interested. And the rare disease community is unique in the sense that we all have personal connections to it. So happy to help. So feel out, and as we say, phone a friend. We're always there to try and help, and hopefully that answers the big part of the question. When it comes to the clinical picture, I won't go into too much detail, but just to show you the complexity, if you look at migraine is a entity, a medical entity, but there is a strong association with migraine and mitochondrial disease, and that opens up a whole can of worms. So most probably not the best to start there. Common things are common, rare things are rare. So exclude the common things. And in Africa, what we find, infectious diseases is still the commonest causes. So get this out of the way and then start looking for the rare.
Thank you, Chris. I'm going to switch to you again, Jolene, here. There's a lot of questions. I don't think we're going to get them all covered today, but we will cover them next week, and I believe the answers will be published on the ASLM website. So apologize if we don't get to your questions today, but we will answer them. So one for you, Jolene, about validation. How can these sampling tools be validated in our settings before their implementation? Thank you for that, Guy.
So one of the things that is extremely helpful is that there is an organization called CLSI, and they can be found at clsi.org. They have published guidances on how to validate a variety of different collections. There is a publication specifically on capillary blood. And essentially what you do is you use matched samples for the original sample matrix that's on a label, like so it might kit might say a red cap tube, and then you would use your alternate sample, and you would test both samples, and then you do a correlation, which is often it's not the Deming regression for clinical. It can be the Deming regression. Which one is it?
Passing-Bablock?
Yes, Passing-Bablock. It's a statistical test where you use the results and you look for how good the correlation is. And then by using essentially the already approved method, you then get your revision as showing it as giving you an equivalent result. This doesn't mean it has to be the same result. It just means it has to be equivalent in the terms that you might have slightly different ranges if you were measuring something in blood versus in serum, for example. There are some of these case studies published, and what I can do is pull, a lot of those are actually on the PCSIG website, so you can go straight to it there, and many of them are open access. If there is something that you cannot find that you find that is not open access, you can often reach out to the corresponding author and request a PDF at no cost. Most authors will be willing to share that. People move around though, so if they're not at the same email address, you can usually find those people on LinkedIn or contact an alternate author. But yes, that essentially it's a process that you go through to demonstrate it. One of the things that PCSIG had been advocating for that has not happened, unfortunately, is that we would love to have ways that labs could pool together and do these supplemental validations so that then any lab can move forward with that modification of an existing approved assay rather than each lab having to do it themselves. That's currently a barrier.
Thank you, Jolene. I'm afraid we've run out of time. We're at the top of the hour now. I just want to say thank you to ASLM. We will be back on Thursday, the 7th of May, at the same time. And at that event, there'll be no presentations, but we'll be having a full panel discussion where we'll be digging into some of these questions that you have about these technologies and approaches. We'll be having an expanded panel, as you can see on this slide given here. And we'll be working with you, the attendees, to think through what the use cases might be for patient-centric sampling for Africa. What are the challenges to bringing on the more widespread understanding and appropriate adoption of these technologies for Africa? And importantly, how do we address these challenges and who do we need to work with, including ASLM and other organizations, to help you move forward to bringing these technologies forward where they are appropriate to help patients in the continent of Africa. So we hope you can attend this event on the 7th of May. If you're interested, as Jolene showed you before, please take a look at our website with the QR code on the left. Join our LinkedIn group. They're all free and a lot of resources in both places. The LinkedIn group is a great place to ask questions and get your concerns addressed. And as Jolene showed you before, there's a lot of content on our website. Please take a look. Please ask us questions. And we look forward to engaging with you again on May the 7th. But thank you for ASLM for giving this opportunity to talk to you.